jail. So we're going to talk about major depression for this and probably a couple videos. So for major depressive disorder, I'm going to have to break it into several pieces. I am in a specialty. There's a lot to know. So we'll do kind of general information for this video. Maybe we'll do a video just on medications, of which there are lots of them. These are just classes of medications like anti-epilepsy medications. There's MAOI inhibitors, antipsychotics, SSRIs, SNRIs, TCAs, tricyclic antidepressants, all this kind of stuff, and just weirdo drugs. And then there's special populations. We can do an entire video on how do you treat people just given a special circumstance, and they're all reasonable ways to do it. All right, so let's just talk about general information with depression now. So let's do the basic outline guidelines. What do you do? What's the algorithm? So first you diagnose major depression, and then you go to a first-line antidepressant, and what makes it a first-line antidepressant is whatever the FDA said is a treatment for major depression. And then when they become manic, you go, whoops, they showed up with depression, but it was bipolar. It's all good. But yeah, so first line is usually SSRI, SNRI. Then it's they typically say observe for 4 to 8 weeks. 8 weeks is weird. I've never seen anybody wait 2 months. I guess if you're overbooked and don't have time to see your patients, I guess that's an option. But most people it's 1, 2, or 4 weeks, depends on the circumstances. And then you could have, you start them on sertraline 50 milligrams, and then they come back in 4 weeks, and then they find out that they're in remission. They no longer meet criteria for major depression. Congratulations. You just treated an adjustment disorder. That's what you call it. They're going to just say they had a bad thing happen in their life. It got better, and you're just medicated them for no reason. But you also get to remission because you've been working on the middle area. It's response but no remission. So you give them medication. It doesn't give them full, it doesn't put them in remission. So you have to keep upping the dose, which is most common. If it seems to be okay, then maybe you just continue to monitor, see if it keeps getting better, because you're already at like 200 milligrams of sertraline. You really don't want to go over, or like 40 milligrams of citalopram. You can also switch or augment, so maybe they had some benefit from it. They want to keep taking the drug, but they're still pretty depressed. So then maybe you add a second drug and you go the polypharmacy route, or you went up on a drug, didn't do much, just switch it, go to something else. Adverse effects can definitely affect how you're going to be treating and doing medication. So if they say you give them medication that is famous for this, and we'll talk about it later, and they get Stevens-Johnson syndrome, they immediately stop that medication, go to the ER. Hopefully nothing terrible happens. But more normal side effects, they get a headache, they get upset tummy, that kind of thing, because you said, I'm going to give you sertraline 100 milligrams because I'm not a very good psychiatrist. And then they're like, oh, my stomach hurts so bad, like you gave them metformin, a gram a day to start off. You would lower the dose, or if it wasn't that bad, it was like a mild headache, then you can just tell them it's going to be okay, encourage them to just keep taking it for a few days and it'll go away. Otherwise, you might end up reducing the dose to where they didn't have that side effect, because maybe it didn't happen at a moderate dose, but it does at a high dose, and they did get some benefit, and then maybe you need to augment it or add a second drug, that kind of thing. But that's that basic idea. So forest for the trees. Antidepressants only help 2 out of 3 people. So whenever you learn about psychiatry, people love a few big trials, the KD trial, the STAR-D, some of these. So the STAR-D is famous for saying, how good are our medications? It was not run by a drug company, so kudos for that. It was run at a lot of different sites, so that's definitely a good thing. So it's hopefully more generalizable. They did it in a, quote, naturalistic, kind of setting, which basically means the doctors got to do what they wanted. They had certain drugs they're supposed to use or certain next steps, but we got to dose it and do what we wanted on that based on the circumstances. And kind of the big take homes from that are going to be that, so 2 out of 3, like we said, of people get helped with kind of the sequence that they went. They didn't augment a person with an antipsychotic or something like that, but it'll help 2 out of 3. The first drug will help 1/3 of the people, and then when you combine all 4 steps of when they did it, it would help 2/3. But this looks weird because you're adding up the numbers. You're well, that's way more than 67%. And that's because, if you had 100 people, 37 got better with the first drug. That means there's 63 people left, and 31% of them got help, so about 20 people. And so the pool keeps getting smaller and smaller that they're treating. Okay. How long do you treat depression? A person has major depression. So The first episode, you typically treat 6 to 12 months. Nobody should be on meds their whole life just because they got depressed once. That's not really fair, and there's no reason that would be the right answer. So typically, you try to get it to where they're not meeting criteria for depression. It's been 6 months of maintenance, or 12 months, and then maybe you do a trial off. Quitting earlier, the argument is it tends to cause relapse more often. People will end up back in major depression. And then you're just like, well, what if they relapse? How long do I do it for? No guidelines. So 1 year, 10 years, 24 days. There's no guidelines. Whatever you and the patient decide. All right. So what do you do when the first one doesn't work? You should probably, if you're doing an SSRI, you should try another SSRI. And there's some logic to that. So doctors argue different patients react differently to different SSRIs, which makes sense. Like you have 1986, fluoxetine came out, Prozac Nation, and that is a big, weird, fluffy molecule. It hits lots of receptors. It is not very specific. And then you get to escitalopram, and that is very specific. It's just an SSRI. So the drugs are different. Paroxetine's not the same as fluoxetine, is not the same as fluvoxamine. I mean, these drugs are very different, except for the ones that are complete copies. So citalopram and escitalopram, that's like going, I'll give you ibuprofen for a headache. It didn't work? Okay, I'll give you Motrin for your headache. Like, yeah, it's the same thing. Paliperidone and risperidone, same story. Okay, so that's why you'd switch. Now, which symptoms are likely to continue? So, according to Dr. Stahl, which everybody will become familiar with at some point if you become a psychiatrist, so some symptoms of depression end sooner than others. And according to him, so the ones that are likely to persist, so a person has major depression, some things are going to persist. And that's basically all the mild signs. Insomnia, fatigue, lack of interest, difficulty concentrating, all the mild things of depression, which if somebody's tired, that's fine, right? Like that's not the end of the world. What is magically likely to get better when you're treating major depression? Oh yeah, they don't want to kill themselves, and they're not super depressed anymore, and they're not laying in their bed, not moving, passively dying, right? That's the whole point. It would be weird if they're like, well, I'm suicidal and depressed, but I'm not tired anymore, and I'm eating pretty well. Yeah, no, these are what you're treating. This is major depression, so I don't know. Take it for what it's worth. Let's talk about some of the terms that you get taught. You're supposed to learn some of these ideas. So, never noticed this. They all start with an R. That's probably why they're hard to remember this way. So it's response, remission, recovery, relapse, recurrence, resistance. Psychiatry sucks at naming stuff properly. Remission matters, so we'll start with that one. This is a real thing. So you have partial and full remission. These are actually specifiers. They're specifiers of major depressive disorder. So it'd be like you'd say the person has MDD in partial remission or MDD in full remission. So these are actual kind of like specifiers set up for in the DSM. Whoops, I think I just clicked twice. There we go. So partial remission means that they're not meeting the criteria for major depression anymore, and it's less than 2 months. When it's in full remission, that means they're not meeting criteria for major depression for at least 2 months. And if we go diagnosis of MDD, you see your famous criteria A in the DSM, which is SIGI caps, right? You learned that since medical school. So you have to meet at least 5 symptoms to be considered major depression. And so when you are in partial remission or full remission, you have 0 to 4 symptoms. There you go. So you'll use those. I mean, that matters. The rest of it's kind of researchy kind of stuff. Maybe your attendings or whoever like it. I'm not going to talk about controversies for this video. So if you found that interesting and you want a medical doctor to keep trying to do YouTube videos and teach people and be part of this big process and demystify the world of medicine, then please smash that like button, share, do whatever. Make sure I show up on YouTube, and I will keep cranking out videos to help you guys out.